Join Dr. Phyllis Palmer, Aaron Padilla, and me in exploring a framework to assess risks associated with dysphagia-related aspiration. Coming up next. Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia care. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you've come to join us for conversations aiming to bridge the gap in dysphagia education and practice. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. Through critical reasoning and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. So for Season 3, some episodes will be eligible for ASHA CEUs. To start us off, Bracco Diagnostics has provided sponsorship for this episode so that eligible listeners can use this episode for a limited period of time toward ASHA CEUs. Please visit swallowthegap.com/podceu, that's PODCEU, for more details. The opinions expressed by these guests are their own and should not be taken to represent their employers. Welcome back, everyone. Today, I'm joined by Dr. Phyllis Palmer and Aaron Padilla. Dr. Phyllis Palmer is the department chair at the University of New Mexico and an associate professor there. Aaron Padilla is an acute care speech pathologist in New Mexico who also volunteers in the dysphagia lab there at the University of New Mexico. So you may have heard their names before. You may have heard a paper, Risk of Adverse Event in Individuals Who Aspirate, a review of current literature and host defenses and individual differences by Palmer and Padilla. And so that's what prompted me to invite them to come on here, and it's a pleasure. Before we get deeper into conversation, anything you would like people to know about you?
Thank you, Tim, for having us here. And it's been a pleasure working with Aaron, and I'll make a plug for the relationship between clinicians and researchers. And when you can find those bridges, I think it improves the quality of the evidence that we put out.
Thanks for having us here today, Tim, and excited to chat with you and just our, off-scene conversations of just thinking about how do we do things tomorrow, of shifting our mindset to that. I think just how do we move our field forward? How do we continue to grow rather than how, I did it this way yesterday and switching to how do I do this tomorrow? So excited to talk about this today.
Well, I think your publication has been pretty instrumental in helping to get people's attention on the fact that we do need to push forward. What within this paper, and this conversation doesn't have to all be about the paper, but I love centering it around this concept of how we reframe things. What was the problem that instigated your desire to publish something? And what is it, like, if you would summarize it, what would you say was maybe the biggest point of this publication, and what problem was it in response to?
I think the big thing, Tim, is, we have to look at the whole picture. And that was one of the main motivating factors for this paper of, if we could give a novice clinician, a seasoned clinician, a pulmonologist, ENT, internal medicine physician, one paper that said, this is why, this patient is aspirating, but this is why we're keeping them on a diet. So I'm thinking about the head and neck cancer patient who, has reduced efficiency, reduced swallow safety, but no adverse events. And when you look at cost benefit, the benefit of keeping them eating and preventing further disuse atrophy and other iatrogenic effects is greater than the cost of making them NPO. So our vision was really, what's one thing that we can hand folks that is a summary of the current literature? And then BOLUS came about of what's an acronym where folks can hang their hat, something that's easy to remember. People can, if you forget the paper, you remember the main points. But I think another thing that's important to remember, and we'll get into this as we discuss things further today, is the standard of care is always changing. So at one point, barium bronchography was the standard of care prior to endoscopic bronchoscopy. And now, we're not instilling barium into patients' lungs anymore, but rather we're using endoscopes to, look at structure and washout and so forth. So things are always changing. More examples of the lobotomy at one point was the standard of care. Now that's, gone. That's no longer. So really just giving a vision of what's coming next. How do we look at the whole paper? How do we look at the whole picture? And I hope that the paper accomplished that.
One of these days, I'm going to give someone cause to bring the lobotomy back. They're just going to be like, we can't shut Tim up. This is the only thing that's going to work. And so, well, we might see that coming back soon. But one thing I want to stop you just for a second. You mentioned adverse event. When you say that, what are you talking about? Or what are some different shades of that? What type of adverse events are you considering?
I think in, the field of swallowing disorders, it can be very vast. It can be, the most significant and severe being death. You can have weight loss, pulmonary sequelae such as pneumonia, pneumonitis, acute exacerbation of COPD, an asthma exacerbation. Those are the big things that come to mind. Dr. Palmer, do you have anything there?
No, I think you covered them all, Aaron. I think that's one of the big shifts that's happened over the last 20 or so years is we used to talk about swallowing and aspiration equals pneumonia, and now we know it's a much broader concern than just pneumonia, that there's many other ways that chronic aspiration can impact health and display itself. It's not just about pneumonia. So, yeah.
Yeah. I have been pleasantly surprised. I mean, it's not ubiquitous, but I've been pleasantly surprised with how many people are interested in things like cough and are talking about oral hygiene and whatnot. Given our aversions, I think it's human nature to have an aversion to risk, right? We want to minimize that as much as is possible. And I see this as something it's not necessarily a formula, like you plug in your patient and you get a value that they are 30%, likely to get pneumonia, not something like that. But what I really appreciate about it is that I think it does reduce some of that uncertainty. And it's not just like you consider this, and you consider that, and you consider whatever, but it gives a little bit more meaning and something somewhat more concrete to it.
Right. Yeah. The basic, I'm sorry, Tim.
No.
A basic tenet of healthcare is do no harm, right? And so risk might be associated with that do no harm thing, right? So how do we minimize harm and or risk? It's maybe by reducing some variability. So I think what things like the BOLUS framework and other, calculators and procedural kinds of things do is they help eliminate some of that variability in patient care so that we're thinking about all the things. And, we all know the Langmore 98 paper, right? And she so clearly stated and that research so beautifully captured that, yes, you need aspiration to have a bad event, but it's not aspiration alone that causes a bad event. And so with that level of variability, how do we rein it in a little bit? And so hopefully the BOLUS framework provides people an easy to remember acronym that walks you through at the bedside so you can remember all of it and reduce the variability across facilities, across clinicians, across the same clinician, at different times of the day or week. So I think doing no harm by having some structured and systematic approaches to assessing risk so that you can know benefit versus risk more clearly and hopefully improve patient outcomes.
That sounds fair. I mean, it sounds extremely practical. What are have you gotten any pushback?
Yeah. Go ahead, Aaron. Yeah.
I think we've heard very positive responses from clinicians of it's just helped, within themselves to help with their care, team building and so forth. And I think it's also helped to shed a light on what a crucial role that speech pathology can play in the multidisciplinary team. If I'm just thinking of, discussions with pulmonary of, this is why we're making this decision, or ENT or GI. And because for our physician colleagues, risk mitigation and risk management is an everyday task for them. So I think if we can start using tools like this that help us to speak that common language, it can really help to increase our value and just really facilitate the team approach of the one common goal of improving patient outcomes. So we've been very fortunate to hear from various colleagues on the utilization and usefulness of the tool.
Aaron, I want to highlight one thing you said. You said the phrase, "This is why we made that decision." And I think that is a key piece that clinicians need to embrace. If you can't answer that question, then you should question what you're doing, right? So, but that's probably a different topic. So we should always be thinking about why we're doing what we're doing. What is it we're hoping to reduce or increase? And then on top of that, we should overlay what are the patient's interests? What does the patient care about? What does the patient hope to achieve?
Yeah, excellent. Excellent. So within the framework, there's the acronym. It's BOLUS, BOLUS. Would you mind walking through what each of those stands for and what that means?
Yeah, absolutely. Thank you, Tim. So we'll kind of ping pong back and forth between Dr. Palmer and I, and we'll start with B first. So B is looking at bolus variables. So we're looking at what is being aspirated. So generally, things of increased density or volume are going to be harder for the lungs to clear out. We're looking at, is the aspirate acidic? We're also looking at the frequency and the amount of aspiration. So when we think of frequency and amount of aspiration, generally the higher the volume and the more frequent, things are immigrating into the lungs. And if the host defenses are insufficient, the elimination process is overcome. And when there are various other factors, as outlined in our AJSLP paper, summarized there, or the original Langmore work, or some of the work of Dr. John Ashford, that's when a secondary opportunistic infection can happen. Things to also look at is there the presence of a cough? Is the cough weak? We know that cough is important for mucociliary clearance and just airway clearance. Was the aspiration silent? That's going to have a greater degree of immigration into lungs rather than someone that aspirates and has a sensate response where they hopefully clear some degree of the aspirate. And just looking at with regards to density or thickness, there's sort of the age-old question of the patient aspirates thin and thick liquids, but the amount of aspiration of thick liquids is less than thin liquids. So do I put that patient on thick liquids because less is going in the lungs? Well, we know from a lot of the work out of Dr. Natif Zeltzer's lab in an animal model that depending on the type of thickener, this can actually cause histological damage to the lungs, and aspiration of water would be easier on the lungs and easier to mucociliary clear. So I think this is where bolus can be used as a discussion tool with the patient on looking at their goals and how can we optimize the care plan moving forward. And I'll pass it over to Dr. Palmer to move on to O in the next part.
Thanks, Aaron. And before I talk about I want to highlight something Aaron said. He mentioned Dr. Langmore and Dr. Ashford. And I hope this gives the image that, the bolus framework is basically taking the current literature. So Aaron and I didn't develop this literature. We took the literature that was available to us and we built it into something that was more user-friendly. So, this is thanks to the work of Dr. Langmore and her colleagues, Dr. Ashford and his colleagues, and many more people.
Yeah.
So I want to highlight that. And O particularly comes out of largely the work of Dr. Ashford, who started with his 3-pillar model, 25 years ago or so, where he talked about, to have a bad outcome, you have to have the aspiration, you have to have some sort of system issue like poor immune function, and you have to have poor oral health. That was his proposal at that time. So O really captures some of Dr. Ashford's original work and looks at, poor oral health creates a pathogenic oral environment. And if we aspirate, if we aspirate when we have that poor oral health, then that higher percentage of bacteria is being transferred to the lungs. So in essence, the oral cavity is not just sitting there doing nothing, right? When you're aspirating, that oral health is being involved in the outcome by transferring those species of bacteria using the food or liquid as a conduit, when that gets aspirated, those bacteria get translated into the lung. And when you have poor oral health, like in a healthy oral cavity, you have about 700 species of bacteria. But when you have poor oral care, you have like millions. It's like 4 billion or something per swallow. So it's not just a small increase in bacteria, it's a huge increase in bacteria. And so the normally balanced microbial communities go insane and create this oral dysbiosis.
Uh-oh. I think she
Oh,
froze up. Oh no.
oh
That's all,
no.
that's all right. We can keep talking, and I'm sure she'll reboot and get back on here with the idea of the bacteria in the mouth too. Something I recall John Ashford saying at a conference years ago was talking about the importance of the virulence of the bacteria. Like it's not just the bacteria load, the amount, but if you have something like MRSA, like you've got a MRSA sore in your mouth and you have a known aspirator, like yeah, that kind of makes the risk a little bit higher if you've got this bacteria that is resistant to antibiotics that is very likely to be transported into the lungs via the conduit of aspiration. So,
Absolutely. And that's a great point, Tim. Yeah, absolutely. And I think, on the topic of oral care, it's really important to mention the type of oral care that is completed. So having something that creates friction like a toothbrush to debride the dental surface, and then also very importantly, rinsing. Because if we don't rinse, you essentially just loosened up all the bacteria. And then now we
yeah,
know this patient aspirates,
yeah,
and there it goes, straight into the lungs. And of course, if the patient's status is not supportive of them rinsing, suctioning out, if a lot easier if they're in a healthcare facility or not. But, our home suction setups and such if needed. So definitely wanted to mention that as well.
yeah. No, really good points. And so I think in a practical perspective, that would take away the option of just using the oral swabs. A nursing or
Absolutely.
an SLP or whoever saying, "Oh yeah, do oral hygiene 4 times or every 4 hours or 4 times a day or whatever frequency it might be," and you just see them getting the swabs and like brushing around in there. Like they're not going to break down that biofilm as much that they need to get the mouth clean. I
Definitely.
appreciate the added aspect of it too, though. Like you don't just need to get it loose from the mouth, but you need to get it out of there so that it's not going to hopefully be aspirated.
For sure. For sure.
So as we keep going through this, we are on L.
So when we're thinking about L and lifestyle and level of activity, we want to look at this through a lens of, and actually all of BOLUS, but I think as we get lower in the framework is where it becomes much more evident of, is this modifiable? Is this not modifiable? Is this chronic or is this acute? So with L, we have three guiding questions. Does my patient have limited mobility or physical activity? Is my patient deconditioned? So is this maybe, they were in the ICU for a while and they were on the ventilator, they were, pharmacologically paralyzed for improved ventilation, and now they're significantly deconditioned. We can hope with collaboration of our occupational and physical therapy colleagues that that's going to be improving. Just something as sitting at the edge of the bed elongates the diaphragm so you can have a more robust cough. So thinking of that, or a separate case of maybe you have someone that has been bedbound for years. How can we modify this? Well, maybe with the assistance of OT and PT, maybe we can get them up to a chair with a Hoyer, and just that act in itself is really going to help with pulmonary clearance. Does the patient smoke or drink with regularity? So with regards to smoking, this is going to diminish mucociliary clearance, which is a innate lung defense, generally considered a secondary defense. Our primary defenses are, a cough, throat clear, things before it gets into the lower airways of the lung. But mucociliary clearance, mucus is attached to the aspirate, and small cilia hair fibers work on moving it from the lower airways to the upper airways, and then it's eventually cleared with a cough. Someone who smokes, that's going to be diminished. But the good thing is if they stop smoking, we should see some improvement of that function. And that's where collaboration with the multidisciplinary team can help. If pulmonary is on the case, definitely running that by them. What are your thoughts on this patient's lung function? How much risk can we take given the lungs, and if there's something acutely going on with the lungs? With regards to alcohol consumption, this will impact alveolar macrophage function, which is, if you think back to biology, you have phagocytosis where phagocytes engulf foreign material and then clear it out. But if there's chronic alcohol usage, this is going to be diminished. And then our final guiding question is my patient dependent on others for activities of daily living, especially feeding and oral hygiene? So just simply put with this, if one is dependent on others, there is a chance that things are going to get missed. Of oral care may not be completed that day. With regards to dependence for feeding, if someone is being fed, there is a higher likelihood that they would have a larger bolus size with liquids, increasing the potential for, immigration into the airway through aspiration, if aspiration is present from swallowing dysfunction. Or, is pacing going to be too fast? So those are the three principles that we have there, and always looking through them with the lens of, can we change it acutely or chronically? How can we address things?
And so just thinking about like there's a lot of variability in the foundations of people who are listening to this, just because so many programs are different, graduate programs are different, CFs are not standardized. Like there's a lot of variability that contributes to variability in our knowledge. So with mucociliary clearance, one of the things I like to think of, you're talking about the hair cells in the trachea, the lower respiratory tract that will kind of capture the mucus and brush it up to where it can be sensed by the recurrent laryngeal nerve and coughed out. Something that will help people to visualize this that I think is really neat. You ever crowd surfing? Like you've gone to a concert, they jump off the stage and everyone has their hands up and they're like moving the person around through the crowd. Like that's what it is to me. All these little arms, these little hair arms in the trachea that are pushing it back up where it needs to.
I love that.
Yeah, no, it made sense to me at least. But the idea for if we can kind of conceptualize what mucociliary clearance is, that's the concept in my mind. And so when you're talking also about cellular clearance, that's more of an correct me if I'm wrong, that's more of an immune system type response where our body is identifying these foreign pathogens that could be harmful and then consuming them or making them, what's the word, dismantling the risk.
That's right. That's exactly right, Tim. And I think some things to highlight of what you just said, what made me think of, the wonderful visual that you provided, is it's a team approach. It's a team approach of the care of the patient with the patient at the center. But also in our host defenses, it's a team approach of the mucociliary escalator engaging if there's aspiration of water, the aquaporins being engaged, which is a ion channel to help clear things, and then as well as the immune function. So just in that short discussion we had, you can see how multifaceted the physiology is to clear things out, and how our approach and management of swallowing disorders needs to be multifaceted, so we have all of the pieces of the puzzle.
There you go. No, man, you're speaking my language. I am going to ask you real quickly for people who might not be familiar, talk just a little bit about the aquaporins in water.
Yeah,
What's that
absolutely.
mechanism?
Absolutely. So, standard of care for lung diagnostics and intervention is bronchoscopy. And sometimes bronchoscopy is therapeutic. I'm thinking of maybe a patient that has a lot of mucus in the lower airways. Say they have a mucus plug, for example. The pulmonary team essentially goes in with a scope, they clear things out, and they lavage the lungs. They instill sterile water into the lungs. And when I'm thinking about water protocol and why does water protocol work, and where did we get water protocol from? I think of the pulmonary team. They're spraying water in people's lungs. They suction some degree out, but those patients
Not
are
going to
not
get all
getting
of it.
pneumonia. Yeah,
Yeah.
exactly. And why are those patients not getting pneumonia when they're already in a, essentially suboptimal pulmonary state that's needing intervention? And part of the answer may be the aquaporins, which are a sodium ion channel that help to move water from the lungs into the capillaries, and then the water is just excreted out through the capillary system. So that's, part of why, my understanding of water protocol being successful. Do you have any other thoughts on the aquaporins there, Dr. Palmer?
No, I think you covered it all, Aaron. Thank you. But just the point that aquaporins are not the only part, right? That there's many roles. And I think one of the distinctions people need to think about is acute aspiration versus chronic aspiration, right? Everybody aspirates a little bit. There's microaspiration and prandial aspiration. And so we get all these responses, these primary lung responses, and then these immune responses. And it's the chronic aspiration that really starts causing trouble because the insult doesn't get a chance to repair. Because even small amounts of aspiration and even water does minor damage to the lung. But the body's really good at repairing it using the algoporins, the mucociliary clearance, all the primary defenses and secondary lung defenses that Aaron has talked about, in addition to these immune responses where they send inflammation to the region that's been insulted and work to repair it. That takes about 24 hours. So if aspiration's a one-off, you're good to go, right? If you start with a healthy lung. But if aspiration's not a one-off, if it's every meal, every swallow, then you get into this loop where the lung can never repair. And so the lung just continues to decline in its function. And that's when you end up with things like cytokine storms, where the cytokines originally are the good guys going in to try and build inflammation and trigger the cells to come out and do their work. But when you keep triggering them to come out, they just go crazy and the whole system breaks down.
Great insight. Great insight. I appreciate that. When I was listening to Aaron talk about the lavage, it's just like that idea that they're infusing sterile water into the system, right? It, to me, presents this idea of cognitive dissonance because we're trying so hard to prevent aspiration. And then you have pulmonologists who specialize in the respiratory system, putting water into somebody's lungs. And so that to me, it kind of presents this question: what do you do when you are encountered with something like that doesn't fit your existing thought pattern or paradigm? And I just think hitting that with humility is so important. I can see that. This kind of goes with what we were talking about beforehand. Like if you have a student who has learned something and maybe a supervisor is doing a different practice, and you're a student and you're like, oh no, the evidence has debunked that so long ago, but you have to present this to your supervisor in such a way that doesn't put them on the defensive. And so like, this isn't, my comment's not going to be about like, well, how do you phrase that question? That could be a whole episode. Or how do you phrase your discussion? But I'm talking about like us. If we were the supervisor or if we are the SLP, we're not right about everything. There's not a single one of us who's right about every single thing. So just that attitude of when you're confronted with things that are different, being able to step back first, being willing not to be defensive, but then analyzing, okay, what's the same? What's different? And so with this, without going into too much depth, I mean, first of all, like the water's sterile. That's one thing. But talking about the aquaporins and, the potential for when you get water into the alveoli for it to be transported into the capillary beds and not necessarily a huge deal, that helps to explain a lot to me of why aspirating water and why water protocols work, why that's not as big of a deal as if somebody's aspirating a sticky nectar thick liquid with fruit juice in it, right? So just kind of a side point there.
Tim, you used the words right and wrong. And I wonder if in medicine, the better words are better and worse, right? So because nothing's right or wrong because of those host variables. Every individual, so I can't have a rule about this drug treats this thing, right? Because it depends on that patient and what they bring, the whole person, what they bring to it. And then, so you're combining what the evidence says with those host defenses. But the other important point that you brought up was about students and communication with supervisors. And I just can't stress enough, there's so much literature being thrown at us right now that no one person can digest it all, right? But students, that's kind of their job, is to digest all the new literature. So as a supervisor, open yourself up to this beautiful gift, right? So that's the give back. You're showing your skills and experience, but what you're getting from the student is, hey, they've just read all the new literature because they had to do it for class. So being open-minded and considering that relationship in a symbiotic way so that there's growth rather than defending your point, unless your point needs to be defended, of course, but being open to that growth mindset, I think, is a really helpful point.
Yeah,
I
thanks
think
for
what
pointing that out. I'm sorry, I didn't even realize that I said that, but that is a great point. The words that I said have implications, but I think that's very important to alter that vocabulary because that communicates something to somebody else. Sorry,
I
Aaron.
think I think what can be, very helpful too is to go at things with a positive but a questioning sort of mindset of help me to learn more,
Mm-hmm.
of, help me to see your perspective on this aspect, or just being upfront. I don't have much experience or exposure to this specific area. What resources do you have? So I have a very fond memory of being a young clinician and wanting to know more about the lungs. And someone very generously pointed me to John West's work, a very prominent pulmonologist on, pathophysiology of the lungs and just all the amount of resources. And I think that openness helped in multiple ways. Number one, it helped to learn more about a topic that I was quite interested in. And then number two, these instances can help to create very productive partnerships and collaborations and so forth. So then, it really opens up the doors for a dialogue, a discussion, and continued growth, I think, is something that can be very helpful for folks.
Oh yeah, absolutely, man. Absolutely. I appreciate that. Thank you for mentioning that example in particular. Let's see. So back to, we got all the way through BOL. Is that where we ended up?
That's right. That's
All
right.
right. All right. Let's talk about what is you.
I'll let Dr. Palmer take it away with you there.
So U stands for unintended influence. And here what we're really talking about are the iatrogenic components. So recognizing how our well-intentioned medical interventions can sometimes inadvertently increase a patient's risk for a bad outcome. And we have it broken down into some categories. So one of the questions is, does my patient have tubes in the oropharynx or airway? And this is a common clinical scenario, right? We've all seen these patients. We place a nasogastric tube, an endotracheal tube, trach tube. Well, we don't, but they have these in, and they're for good medical reasons. But when the tubes are sitting there, they attract bacteria just the way our teeth and oral cavity does. So we're in kind of that same situation where we're increasing the pathogenic bacterial colonization. And so if we think back to we know that more bacteria means when we aspirate, we introduce larger amounts of bacteria into the lungs. So what's being aspirated is more pathogenic. The other thing is just the mere placement of the tubes. Like if I have an NG tube and it's going through the upper esophageal sphincter and whatnot, it can reduce UES opening. It can reduce laryngeal sensation. It disrupts normal swallow mechanisms. So we have to be thoughtful about that. Or trach tubes, it changes pressure differentials, and swallowing is a pressure-driven event. So it's all about the pressure. And trachs will change that, changes coordination between breathing and respiration. The next question under U is my patient receiving mechanical ventilation? And you'll notice that each one of these questions you can say yes or no to. And so the vision is that the more times you say yes, the more trouble your patient might be in, or the more risk your patient might be having to endure. But when we talk about mechanical ventilation, this question talks about, obviously ventilators save lives, right? But there's something known as ventilator-associated pneumonia. And about 25% of our patients on mechanical ventilation will end up with a pneumonia from the ventilator.
That's a lot.
Sorry, Tim.
No, I was just saying that's a lot.
Yeah, that is a lot. Yeah. Yeah, I mean it's too big to be unrecognized, right? The next question is, and this one's a really big one, is my patient on medications with side effects that impact alertness, cognition, immune function, or saliva production? Because all of these things can be linked to, while they're fixing something else, they're causing these other problems. And when I have reduced alertness, reduced cognition, poor immune function, or poor saliva production, I increase my risk value. So anybody who's on antidepressants, sedatives, opioids, those are all medications that can alter alertness or cognition. Saliva production's a big one, right? Because almost everybody has allergies and is on antihistamines or decongestants or some kind of medication that might alter saliva production. And we know from Dr. Ashford's work that hyposalivation increases oral bacterial counts. And then, of course, there's the medications that suppress immune system. So if you had a recent transplant or you're on some sort of chemotherapy agent and you're suppressing your immune system, then even small amounts of aspiration can then be problematic. So that kind of captures the iatrogenic or the side effects of our other treatment approaches.
Yeah, there's a lot there. I mean, we could diving into each one of those, we could, talk, I think, about them at least 10, 15, 20, 30 minutes. So this is an overview, just so everybody knows. I would first of all encourage you to go and read the paper yourself, and I'll post a link to that on the podcast episode. But if you think of questions later, more things that you want to discuss, send me an email, tim@swallowthegap.com, and I can forward those along. So
Tim?
now, yeah.
Tim, I'm going to say one other thing. You keep talking about the paper, that's the 2022 paper, which is sort of a review of the literature, but it doesn't present the bolus framework. There's another paper that's in Frontier, which is an open source paper, so it should be available to all clinicians. And I can send you the link to that if you'd like to share it. It's in Frontiers in Rehab Medicine, and it's called something like linking
linking the
aspiration.
impact of aspiration to host variables using the BOLUS framework, support from a rapid review.
Yeah,
Oh,
so
that would be awesome.
that might be a nicer paper because it gets people closer to the actual implementation science, whereas the 2022 paper gives the background and the 2024 paper gives the implementation. So
That would be excellent. Thank you.
yeah,
Thank you for pointing that out. I appreciate that. So now we're on S, right? Are we through anything else with you?
no, we're good.
Okay, cool. So for S.
We're in the home stretch here with BOLUS. So S stands for system status, and again we have our glasses on looking at modifiable versus non-modifiable, acute versus chronic. The first question we have is the patient frail? There's some ongoing work by Dr. Sonia Molfenter looking at frailty, role of protein supplementation in dysphagia management. So just, on a broad level, if someone's frail, they may have reduced physiologic reserve. So they may have swallowing dysfunction, they're managing things okay, but now they have some sort of acute event. They have a stroke, they're admitted to the hospital with something. They may not have enough physiologic reserve to manage the aspiration that was chronic. Or now maybe because of their frail status, maybe the amount of aspiration has increased. And with frailty, if there's reduced mobility, we discussed that in L, how that's important for pulmonary hygiene. We want to look at, does the patient have respiratory disease or GI disease? We talked about our pulmonary defenses earlier today. Those are going to be diminished in someone that has respiratory disease. With regards to GI disease, if there's reduced esophageal clearance, there's potential for retrograde aspiration or potentially aspiration of solids, which would be much more caustic to the lungs. Or if there's aspiration of gastric contents, that's going to be a lot more harmful to the lungs than anything prandial that's going into the airway. Does the patient have limited cognition? Is this acute or is this chronic? We just talked about iatrogenic or unintended effects. Maybe the patient is in an acute confusional state because of medication that they're on right now, or maybe they're confused because of a urinary tract infection, and we suspect this will get better with supportive care. Or perhaps it's chronic, secondary to the patient living with dementia. What sort of external supports does the patient have that can help to reduce the odds of an adverse event? We talked about immune function and the extent of iatrogenic impacts of immune function, but we also want to consider maybe it's something acute too of high dose steroids or chronic, like Dr. Palmer mentioned in the oncological case or transplantation case. And then lastly, we have reduced cough response or cough strength. So knowing that cough is an important factor for clearance of aspirate, this is, generally a modifiable factor, and lots of exciting cough work going on out of Dr. Trochet's lab. How can we engage cough intervention into the management plan for the patient and so forth?
Excellent. Something that I can't help but to think about as you're going through this, there are so many variables. There are a lot of different things. And so just even taking a couple of steps back each day, or each day we go into the clinic, and questioning the decisions that we're making. Okay, why am I doing this? Trying to have more of a rationale, just continually digging deeper. I feel like it's an onion. You peel off one layer and you get a little closer, but there's still questions. So you peel off the next layer and you keep going, and we will never get there. We'll never get there to like 100% certainty. Probably not. But just asking questions like, okay, this is what I'm used to. The patient aspirated thin liquids on their MBS or their fees. So I'm going to immediately go to nectar thick liquids, just asking the question, why? Why are you doing that? And I think when you ask that, okay, because I don't want them to get pneumonia. But then that gives you a platform to say, okay, what else matters with pneumonia? If you keep asking why and digging deeper, you'll tease out a lot of these things on your own. And I think both of these papers will be excellent resources for people to be able to further elucidate that. I know we're getting close on time. If we have time, I'd love to give a real fast, practical application for, like, say we have a patient who walks in. This patient has, let's see, they are 5 years let's go with something a little more straightforward. This patient has never had a stroke before. They come in with a right hemisphere stroke to the middle cerebral artery. They present with X, Y, Z, whatever. Let's just say they have some oral phase deficits. They aspirate infrequently. I don't even want to go there because I feel like you guys will answer these questions. What I want to do is just present a very basic thing and then kind of walk through the application of this. Like, what questions are you asking? So if you have a patient who is referred to you, they are 24 hours post a right middle cerebral artery stroke, what's one of the first questions you're going to ask?
Yeah, I think you bring up a great question, Tim. And one of your recent guests, one of our colleagues, Dr. Janina Wilmscotter, has some work on lesion-specific mapping and swallow physiology. So, if you're having this case presentation, something where my brain is going to go to is, where is the lesion and what does the data say about the physiologic findings that we're going to have as a result of that? So that's going to help me in my management plan. Other things that I'm going to look at is, this patient just had a stroke, so there's a degree of immune suppression. So if neurology is on the case, I think it can be helpful to talk to neurology. And how long are we suspecting to see this acute immunosuppression to be? Because that's going to change the management plan that we have, and that may change how we balance risk and so forth. Does that answer your question?
That
helps. I think that gives a good start.
Can I overlay something on that? So
Yeah.
Aaron very, very nicely laid out that, we need to address the physiology. So what's broken, right? And we need to address what's specific about this host, immune suppression or whatever comorbidities they bring to the party. The third part is, what does the patient hope to achieve? And what are the desires of the patient? Where do they want to go? So, for example, if I'm working with a patient with head and neck cancer, one of the things we do is we have them talk to other cancer patients, and they have kind of an idea of what's going to be happening as they go through this pathway of treatment. And so usually up front, I like to say, okay, this pathway is not an easy pathway, right? Do you want to, at the end of this path, do you want to eat orally or not? Because that will dictate how I cheer you on or how I direct you or how I support you. What's your long-term goal? Because some people are like, just make the cancer go away. I don't care if I never eat orally again.
Mm-hmm.
Some people have a different opinion. They're like, no matter what, I want to eat my green chili cheeseburger. So
don't assume you know what someone wants.
Preference. Right.
Absolutely. Right. Yeah. Great point. Great point. So going into this patient, let's assume that they want to eat the least restrictive diet. Maybe they don't even know what type of risk they're willing to tolerate. But you're coming back to the B part of the framework. You see that on fluoro, they're aspirating thin liquids. You're going to look at frequency, right? Like how often are they aspirating this? How do they respond to it? So say, I don't know, what else within that? You get this right MCA CVA patient. If they're immediately 24 hours, you're going to be more concerned about their immune system. But it sounds like maybe if they're 3 weeks out, that's going to change that parameter and you're that's maybe less of an issue to you. So the implications of that, I'm assuming, is you've got a little bit more aspiration maybe you're potentially willing to tolerate, assuming that all other variables are the same, right? Am I following your line of thinking?
That I think you bring up some important points, Tim, of looking at the timing of things. And that's one thing that we know with, stroke of hopefully it's a one-time event. There are instances where the patient can have a, recurrent stroke or extension of the stroke and so forth. But generally you have this one point in time where you have an anatomical disruption and difference. And then we would expect to see some degree of recovery. So looking at where is the patient in this journey of recovery? If it's acute, I may be more conservative in some measures as we await time and spontaneous recovery, as well as further intervention. If it's been more time, as you mentioned, then there may be more risk that we can take, especially if the patient is mobilizing with nursing staff, family, occupational therapy, physical therapy. I think some other things, you mentioned the video fluoro and the patient aspirating thin liquids. I think something to consider is when you're attempting compensatory strategies, maybe they were unsuccessful in omitting aspiration completely, but if they reduced the amount of aspiration, there's still some success in that of reducing immigration into the airway. Does that get at your question?
And I'm going to turn the example a little bit, Tim, to how would we apply the bolus framework here? So you want the patient to have the patient wants the least restrictive diet. And so you're trying to assess how reasonable is that? What risk is acceptable? And the bolus framework can be a series of questions that you ask yourself to get, the violations are in B. These are modifiable. Most of the B section is modifiable. Can I eliminate, reduce anything that's modifiable? But looking at all the other letters as well, like, okay, so if they're aspirating only thin liquids once in a while and they have good integrity under O, L, U, and S, we might be okay. If we go through the rest of the bolus framework and we see, hey, there's a lot of risk violations here, or then maybe we think more carefully about how we go through the clinical process and what's acceptable. And also using that bolus framework to educate our patients so they know what the risk factors are. Like, hey, if you brush your teeth more, this might be okay, or whatnot, something to that.
No, that makes a lot of sense. That makes a whole lot of sense. I don't mean to overly focus on like isolating any one of these because I realize they all relate together. But I'm curious about how, like, with this patient, if you're just going through bolus variables, oral health, lifestyle ADLs, iatrogenic risks, and their system status, just kind of a couple of touching points. It's not going to be comprehensive, but almost like a summary. Like we talked about what all these things are, and so for this, okay, here's our patient. These are a couple of things that are going to exemplify each category. Certainly not comprehensive, but kind of looking at that. So to really put this in the framework of an actual case that someone might be looking at. So if I'm going through this, I have this patient who has had whatever type of stroke. A lot of considerations about their premorbid brain health too, because that can be a predictor of dysphagia severity, where the lesion is, how big the lesion is. But let's just say we're looking at their swallow phenotype or their presentation of what their swallow looks like. So maybe they aspirate thin liquids, less than a quarter of the bolus, half the time. So you'd be looking more at frequency, maybe what they're aspirating. Are they aspirating thicker liquids too? What questions am I missing within there, or did I conflate maybe to a different category?
So if we're just looking at B and you're saying they only are aspirating thin liquids, yeah, you could consider if thickened liquids will buy you something, buy you a little more safety, or having their thin liquids separated from meal times with a cleaner oral cavity, right? So I think either one of those, the where I think people get stuck is if they automatically knee jerk to thickened liquids, and the thickened liquids don't eliminate the aspiration. Now they're aspirating something that's more caustic and damaging to the lungs.
Yeah. Harder to clear, heavier, stickier.
Mhm.
Okay. That helps. So moving on from bolus variables, oral health. I mean, it's kind of, to me, it's at least intuitive, right? But what maybe are some practical things that you would implement within your facility for this patient? Are you talking to nurse about the importance of oral care using a toothbrush that has friction and not just the oral swabs? Like, what are some measurable steps you might take?
Yeah.
Yeah, I think what can be helpful is, say someone's in a rehabilitation setting, for example, or facility, or even in the hospital, taking a multidisciplinary team approach can be the most successful of maybe each nurse shift. So say you have nursing shift is 12 hours. Once a shift, the nurses, if they can complete oral care. When speech pathology consults, speech pathology can complete oral care. Maybe the patient can work on ADLs with occupational therapy and complete oral care. So right there, we have four instances of oral care throughout the day. And then, of course, the patient, engaging and being proactive in their own oral care would just add more additional instances for that. I think is where clinicians can find the most success in implementing some sort of oral care regimen.
Yeah, I love that. And that's very concrete too. It provides someone with application, not just, oh, hey, consider oral hygiene, but okay, you've considered it. So now what can I do? So yeah, thank you so much for that. Lifestyle and ADLs.
That's
I'm sure
I'm
it's broad,
giggling.
very broad.
I'm giggling because I have a memory of a patient who I said to him, so I'm gonna give you some recommendations, and he said, "Oh no, not the L word." And I said, "What's the L word?" And he said, "Lifestyle change." And so I always, whenever I think of that, I think of, oh, well, for some people, that's a huge deal. Like, stop smoking. It sounds like a no-brainer to me who doesn't smoke, but it's not a small ask. So really, I think here is where education is kind of helpful and letting them know that even a little bit buys them more. Like Aaron was saying, there's this really beautiful literature right now that you don't have to walk around the block 5 times. Sitting on the edge of your bed makes a difference. And if that's really all you can manage, let's cheer that on. But I think helping transition people to independence in oral care, independence in feeding, working with our OT colleagues to help achieve some of that are really useful goals for patients. And Aaron, I'll let Aaron say more about it. So.
And I think on that point too of the mobility piece, what can be very easy to implement for patients, because, in your case example, Tim, you imagine you have speech pathology saying do ABC, PT saying do 1, 2, 3, and OT saying do XYZ. And then, of course, you have all the other members of the multidisciplinary team, RT, internal medicine, neurology, nurses, telling the patient to do all this stuff. And they may feel so overwhelmed by all of it. So, how can we put this in a functional way that doesn't add more stress to their plate? Maybe something as simple of, if the patient's mobile, after you eat, go for a walk around the unit. If the patient isn't mobile and they can, their current status is sitting on the edge of the bed, after you eat, sit on the edge of the bed and do your cough exercises. So we're at least moving stuff around in the pulmonary system. And that can help patients not only with buy-in, but also a sense of success and a sense of ease of implementing their exercises and or their management plan. And then it becomes routine, second nature, and it just really helps to catapult them forward.
Well, with your example of them walking around the unit, now it's like, oh, you want me to walk? PT also wants me to walk. I like this. Like it's easier. It's not two separate things, but you're both helping me to understand the importance of that one thing, and you're working very synergistically, which is cool.
Absolutely. Absolutely.
All right. So to the you, to the you.
I think we have very little control here. You can't go in and scrub somebody's endotracheal tube. I mean, trach tubes you can actually take out and clean and put back, but like an NG tube, unless you pull it out and rechange it, which may or may not happen depending on where a patient is. So I think here's a place where we need more research, we need more understanding, and these are in the more non-modifiable category.
Yeah.
And we might just have to strengthen the other aspects of bolus and make peace with the U. So I think some parts of U and S, we can't change that you have COPD. We can't change that you have a tube right now because you can't breathe without it, or the
Sure.
vent is keeping you alive. So
Yeah. Makes a lot of sense. Things we can't change, being mindful of that. I mean, that apply. How many different areas of life does that apply to as well? We know that this X affects Y and A affects Y and Z affects Y, but we can only change A. Or it's going to be really hard to change Z. Sorry, go ahead.
But the converse of that is, we identify, hey, these are the things we can't change about you, sir, but these are the things we can change.
Mm-hmm.
Let's work on these modifiable things, and let's educate our patient to know what those modifiable things are. So when they're not in your care and they're making choices, they can make the choice that they want. I mean, they can make the choice they want, but they can make the choice fully understanding, hey, if I eat my meal without brushing my teeth first, I might take more bacteria into my lungs. I know that, and I'm still going to do it. And, or I know that, and I'm going to make the effort to do it right. But it's their choice.
I love that. I love that. And even if to take it even further, there's a framework in business, and I've mentioned before, it's the impact versus effort. On one level, you have what is the impact of this? And let's say, it's probably going to be high impact. And then you have things that are going to be low impact. But then triangulating that with how much effort is this going to be, or how much of a burden to the patient will it be? So something like oral hygiene is pretty high impact and it's pretty low effort. So I like to, if we put that in the framework of talking to the patient about things that they can do that are modifiable variables that are likely to make a difference, but even like based upon what we know, this is likely to be one of the most important things that you can do. But then they have the input of like, well, that's going to be really hard for me. Like I can't quit smoking. And so even though that might be big impact, that's too much effort. They're not willing to do it. But then you can say something like, okay, you willing to work with this respiratory muscle pressure threshold device? Or are you willing to get up and move around and brush your teeth? Those types of things might be big impact, but lower effort. And so like that, it seems very strategic, and it also kind of puts it in their court too. Like we provide the education and they decide, okay, based upon what you tell me about how much that's going to help and how much effort I'm willing to put forward with PT and OT and RT and everybody else telling me I got to do this, got to do that. Like I can handle that right now. So anyway.
I love that vision of making rehab active rather than passive for the patient. And so as clinicians, I see one of our roles as gauging what is their level of interest, so you want to lose weight. What work are you willing to put into that? You tell me and I'll support you in that. Because that's really, I think, our goal is to provide the information, right? And they get to decide where they want to go with it.
Yeah. So lastly, before we wrap up, system. A lot of other things we can't change, but how is that still with this patient going to influence where you go?
Yeah, absolutely. Great question, Tim. And this brings me to a member of the multidisciplinary team that I haven't mentioned yet, and that's our dietitian colleagues. Of maybe this patient that we're talking about that has had this stroke was pre-morbidly frail. How can we collaborate with the RD team to see how can we optimize nutrition hydration orally for this person? So that's one aspect that I don't want to mention. With the right-sided CVA, if there is a higher likelihood of cognitive aspects of communication deficits, what level of supports do they have? This, any external or internal family support in the respective setting they're in, whether it be acute care, inpatient rehab, skilled nursing facility. And then, as we alluded to earlier, looking at where they are in their recovery phase and how that will impact immune function. And then engaging cough in some capacity. And an idea that our colleague Lori Winterholm shared with us is having the patient do their cough exercises after they eat, because that's going to be moving stuff around. And then to our example earlier, it's less on the plate for the patient.
Work smarter. I mean,
yeah, exactly.
Yeah,
exactly. That's exactly right. And those are really all of the, things that I think of when we think of system status for the hypothetical case that we had there.
No, that's great. And I can, oh, sorry, go ahead, Phyllis.
I'll add one more thing. So many of our patients suffer polypharmacy because Aaron highlighted, and this is a key thing under S, is that we have a team that we're not working solo, right? We have a team. So for patients who come with long medication lists, communicating with our pharmacy and medical guys to say, can any of these be eliminated if I can get them more cognitively intact or more alert? We might have better outcomes in our rehab pathway. So.
That's great. I had to write down a note with that. I have a good buddy who works at Huntsman Cancer Center in Salt Lake City, Utah. He's an oncological pharmacist. And I'm like, I got to get him on here to talk about polypharmacy and infection risk because, yeah, that's excellent. I really cannot overstate how much I believe this work is pushing us in the right direction. Are we there yet? We're getting closer, and this is really, we're on the right path. This is fantastic, and thank you so much for being willing to talk about it. Next steps within this, where do you think we need to go from here?
I'll talk about the BOLUS framework specifically, and then maybe Aaron, you can address where we need to go with patient care. But, I think the BOLUS framework provides a beginning part, right? It provides a framework. And what we don't know is, are there specific sub-questions for different disease categories? So maybe there's the BOLUS head and neck cancer framework, the BOLUS stroke framework. So I think Aaron and I are working on putting together what are those questions that we would add for those specific clusters of patients. Not everybody gets radiation, but radiation probably has a huge effect. So for head and neck cancer patients, that becomes an important question. So thinking about those patient-specific questions that could enhance the framework, and then also thinking about weighting. So maybe one thing is more important than another. So how would we weight each question or each category to give us an idea of, well, all their infractions, all their risk infractions are in this low risk category, or they're all in this high risk category. So it'd be nice if we had some idea of what weight do these each carry, and does that weight change as a function of patient population and comorbidities and whatnot. So that's where we're going next with this.
Wonderful. Wonderful. Aaron?
And I think in terms of clinically, where do we want to go? The data offer that it takes about 17 years from time of publication to implementation. So I think as clinicians, a avenue that we can strive to go down is how can we implement more of the current evidence into our clinical practice to improve patient outcomes? I think, in 2025, the scene has definitely changed where the availability of resources is so robust of, podcasts and online CEUs, free open text journals. How can I grow within myself, but how can I grow within the respective team that's one is in? Maybe this looks like having a quarterly grand rounds with your, its respective institution, or if you're maybe in a rural place, with your neighboring community, or doing the same with a journal club or so forth. I think we just have so many generous people in our field that are so willing to share their knowledge and their information, of maybe inviting someone for a lunch and learn, for your setting, and just, talking about their line of work. How can we implement this into our practice? And I think the last thing I would say is the message that we started with, of how do we provide care tomorrow? How do we grow? How do we move forward? So I think always having that mindset can really just help us to help the patients. And I think if you look back at the beginning of everyone's career, when they get that acceptance letter to graduate school, the why of they went on this journey, they wanted to help people. They wanted to improve, patients' lives. And if we stick with that spirit and that positive mindset, I think what we can do is amazing things.
Thanks for bringing it full circle. I appreciate that. And it reminds us and it highlights There are more barriers to changing clinical practice for the better than just whether or not there's a research article published on something. I mean, you express the lag between when something is published and implementation science, right? So much that is there. And I think from, the data to the mindset of how we receive that data, to the strategies that we share that data and help to make each other better, all of those things just work together beautifully from this holistic perspective of how do we push things forward? How do we become better? Can't really think of a better way to end this than with that. So I really appreciate your perspective. Great minds. Dr. Phyllis Palmer, Aaron Padilla, thank you so much for being on here, and look forward to keeping in touch.
Thanks you
Thanks
for
for
having
having us,
us.
Tim.
Yep.
And thanks for what you're doing for our field, Tim, of really bridging the gap there. We really appreciate that.
It was an honor to finally have the opportunity to chat with Dr. Phyllis Palmer and Aaron Padilla about the BOLUS framework. Thanks again for tuning in, and remember to look in the episode description for more resources. And also, there is the opportunity, thanks to a sponsorship by Bracco Diagnostics, for eligible listeners to take advantage of continuing education credit for this episode for just a limited period of time. For more details on this, go to swallowthegap.com/podceu. That's swallowthegap.com/podceu. Thanks again for tuning in, and I'll see you next time.